Hi doctors, I am Dr. Thirunavukkarasu, Professor of Pharmacology from DAMS. In this video, we are going to discuss FMGE Pharmacology recall questions. We'll start. The first question I am going to discuss from ANS, what is recalled from the FMGE paper. A lady was stung by many bees. She developed breathing difficulty and hypotension. Drug useful for treating this condition is what? The option given are adrenaline, noradrenaline, dopamine and isoprenaline. The right answer for the question is option number A, adrenaline. Why? Look at the lady was stung by many bees. Following the bite of the bee, the lady developed difficulty in breathing and hypotension. So, it may be a case of anaphylactic shock. For an acute anaphylactic shock, the drug of choice is adrenaline. Now, just to spend 1 minute time, acute anaphylactic shock can be due to a drug therapy or due to insect bites. Here, the most important chemical causing problem is histamine. The histamine acting on H1 receptor in the bronchus causing bronchospasm, thereby causing difficulty in breathing. The histamine acting on H1 receptor in the blood vessel causing vasodilatation, thereby causing hypotension. This is a problem of anaphylactic shock. For this case, the drug of choice is adrenaline. Adrenaline. Why? Adrenaline having action on bronchus as well as action on blood vessel. Look here. Adrenaline by acting on alpha 1 receptor in the by acting on beta 2 receptor in the bronchus causing bronchodilation. By acting on alpha 1 receptor in the blood vessel causing vasoconstriction, thereby overcoming the problem of hypotension. So look here, adrenaline by acting on beta 2 receptor in the bronchus causing bronchodilation, thereby overcoming the difficulty in breathing. And adrenaline acting on alpha 1 receptor in the blood vessel causing vasoconstriction, thereby overcoming the hypotension. So, the drug of choice for treatment of anaphylactic shock is adrenaline. Along with that, we can use antihistamine steroid, that is supportive therapy, but drug of choice is adrenaline. In this one extra point you should know, look here. The problem of anaphylactic shock is due to activation of histamine receptor, H1 receptor. But we are antagonizing the histamine action by using adrenaline, but adrenaline acting on beta 2 and alpha 1. Adrenaline not going to block histamine receptor. See, adrenaline overcoming the problem of histamine but not acting on histamine receptor. This type of antagonism is called as physiological antagonism. This is also important point you should know. Physiological antagonism. That means the best example for physiological antagonism is adrenaline antagonizing histamine induced bronchospasm, and histamine induced vasodilatation is the best example for physiological antagonism. Extra one point you should know, for treating anaphylactic shock, the best safest route of giving adrenaline is intramuscular injection, IM injection. The 2.5 ml of 1 in 1000 solution. The dilution should be 1 in 1000 dilution intramuscular. That is safest route. Alternate route is subcutaneous, but don't use intravenously because adrenaline is arrhythmogenic causing problem. So don't use IV. If at all if you want to use IV, go for 1 in 10,000 dilution. But generally, for treating the anaphylactic shock, adrenaline, the safest route is intramuscular injection. That's about first question. Coming to second question, which one of the following is the action of dopamine at low doses? The question, action of dopamine at low doses. That means dopamine having different action on different dose. I'm going to discuss that. Before that, look at the option. Increases renal blood flow. It produces positive chronotropic action. It produces vasoconstriction. It causes hypotension. What is the right answer? The right answer for the question is it increases renal blood flow in low doses. Now I go for explanation. Look here. Dopamine actually a catecholamine, but dopamine available as a drug. As a drug, dopamine acting on three important receptors. It acting on D1 receptor, beta 1 receptor and alpha 1 receptor. But these actions are based on dose. For example, when you give dopamine less than 2 microgram per kg body weight, it mainly acting on D1 receptor. When you give more than 2, that is 2 to 5 microgram per kg, in this dose, it may acting on D1 as well as beta 1. Whereas in high doses, say more than 5, that is 5 to 10 microgram per kg, in high doses, the dopamine acting on all the receptors, namely D1, beta 1, alpha 1. So, in your question, in low doses, dopamine acting on which area? It mainly acting on D1 receptor. When I say low dose, I mean less than 2 microgram per kg body weight. Now you should know action. Look here. The D1 receptor especially located in the renal blood vessel. Renal blood vessel. So, when you give dopamine less than 2 microgram per kg body weight, by acting on D1, it causes renal vasodilatation. By causing renal vasodilatation, it is going to improve the renal blood supply, increases renal blood flow. By improving renal blood flow, it is going to improve kidney function, thereby it is going to promote urination. That means in low doses, dopamine increases urine output. Point 2. It also having action on beta 1. Beta 1 receptors are mainly seen on myocardium. So when I give dopamine in 2 to 5 microgram, it may acting on beta 1 also. By acting on beta 1, it may increases the force of contraction. Increasing force of contraction. By increasing the force of contraction of heart, it going to increases cardiac output. Increasing cardiac output. And when you give more than 5 microgram per kg body weight, this is 5 ton. In this dose, it acting on D1, beta 1 and alpha 1. So by acting on alpha 1 receptor seen on peripheral blood vessel. By acting on blood vessel causing vasoconstriction. By causing vasoconstriction, it may increases blood pressure. So ultimate point, dopamine increases renal blood flow, thereby increasing urine output. Dopamine increasing force of contraction of myocardium, thereby increasing cardiac output. Dopamine causing peripheral vasoconstriction, thereby increasing BP. Now look at the point. Because of increasing cardiac output, because of increasing BP and because of increasing urine output, dopamine is a fantastic drug of choice for treatment of cardiogenic shock with oliguria. Oliguria means the patient is passing less amount of urine. So remember, the drug of choice for treating cardiogenic shock with oliguria means think of dopamine injection. Okay, and for your question, in low doses, dopamine mainly acting on D1 receptor. Okay, next. A patient presented with weakness of limb muscle, especially in the evening after work. These symptoms improved after hydrophonium test. This patient is likely suffering from which one of the following conditions? It's a straightforward question. Okay, a patient having muscle weakness and having tiredness after work, having tiredness, fatigue. And the fatigue was improved by using edrophonium. Look here, edrophonium is one of the anticholinesterase. Edrophonium is anticholinesterase. That means it's going to improve the acetylcholine level. But it's a reversible drug, very short acting. So transiently going to improve the level of acetylcholine, thereby transiently going to improve the muscle power. If a patient improving the symptom by using edrophonium, definitely he is suffering from myasthenia gravis. Answer is option A. Okay. Now go for discussion. Actually, myasthenia gravis, very simple, is an autoimmune disease where there is an antibody formation occur against the nicotinic receptor. See, I think acetylcholine having action on muscarinic and nicotinic receptor. Nicotinic we have NM and NN. Now, in myasthenia gravis, there is an autoantibody against NM receptor. N stands for nicotinic and M stands for skeletal muscle. So, there is an antibody against acetylcholine receptor on this skeletal muscle. Thereby, the acetylcholine is not able to bind on NM properly. Thereby, the patient developing muscle weakness. So, this patient will have muscle weakness, having the complaints of fatigability, tiredness, especially after long work, and they have ptosis, muscle weakness, not able to speak continuously, all these symptoms. Okay, how are you going to diagnose? Okay, we have one drug called edrophonium. Edrophonium is a reversible short-acting anticholinesterase. Thereby, it is going to improve the acetylcholine level for short period. When you improve acetylcholine level, they are going to improve muscle contraction, thereby overcoming the symptom. That is called edrophonium test. It's also called tensilon test. Tensilon test is useful for diagnosis of myasthenia. But the tensilon test is a non-specific test. So, what is the specific test and what is the confirmatory test? Look here. The most sensitive diagnostic test for myasthenia is demonstration of autoantibody. I put antibody against acetylcholine receptor. By doing radioimmunoassay, you have to demonstrate there is a presence of antibody against acetylcholine receptor. That's a sensitive test. Whereas the confirmatory test is single fiber electromyography. We call simply EMG. Electromyography is a confirmatory test. Anyway, one easy test is edrophonium test, but the confirmatory test is EMG. Okay. Now, extra 2 to 3 point I want to tell you. For treating the myasthenia gravis, the first line drugs for treatment, the first line drugs are we having neostigmine, pyridostigmine. All these are anticholinesterase. They are going to improve acetylcholine level, useful for treatment of myasthenia gravis. Other than anticholinesterase, we have some more drug. For example, it is an autoimmune disease. So, to control the antibody activity, we have some immunosuppression. There are some immunosuppression useful for treatment of myasthenia. For example, steroids, azathioprine, mycophenolate mofetil, cyclosporine, even cyclophosphamide, all these having immunosuppressive property. Other than this, one important point, we can also try some surgical intervention like thymectomy, because most of the autoantibody are formed from thymus, so we can plan for thymectomy, or we can remove the antibody from the plasma by using plasmapheresis, or we can use intravenous immunoglobulin. That's also very good choice for treatment of myasthenia. These are options. So, in your question, the diagnosis test edrophonium is useful for diagnosing myasthenia. And finally, a myasthenia symptom can be rapidly treated by using either plasmapheresis technique or by giving intravenous immunoglobulin? Once again, a rare question can be asked, that means the myasthenia gravis, muscle weakness, can be aggravated by using some antibiotic. What are all the antimicrobial agents going to aggravate myasthenia? For example, aminoglycosides, quinolone, macrolides and quinine. These group of antimicrobial agents also going to aggravate myasthenia gravis. So be careful while using these drugs in myasthenia gravis patient. That's important. Okay. Next question. A patient is on treatment for myasthenia gravis presenting with increasing muscle weakness. Which one of the following drug is useful for differentiating whether the patient is having myasthenia gravis problem or cholinergic crisis problem? Okay. Patient is on treatment for myasthenia. Even though on treatment, there is a worsening of symptoms of myasthenia. So how are you going to differentiate whether it is due to myasthenia crisis or cholinergic crisis? Options given are edrophonium, atropine, pyridostigmine, pilocarpine. Just though I told, edrophonium is useful for diagnosis. Look here. If we give edrophonium, if the symptom relieved mean the patient is having myasthenia gravis problem. If the symptom worsening mean he having cholinergic crisis. Because edrophonium, I told, anticholinesterase. It is going to accumulate acetylcholine. When acetylcholine get accumulated, the symptom should get recovered. If the symptom aggravated, that is called cholinergic crisis. So edrophonium is useful for differentiating this condition. Next question. After eating an unknown plant, a child was presented to the emergency department with a comatose status. The pupils were dilated and the skin was dry. Body temperature was raised and the heart rate was very high. These signs and symptoms can occur with intake of which of the following substance? Look here. The child was taken some unknown plant. Following that, developed unconscious status. On examination, people were dilated and the skin was very dry. Temperature was very high and the heart rate is also high. Now look here. People dilated and then skin was very dry, no sweating, skin was dry and heart rate is very high and also there is a altered level of consciousness, comatose status. All these things are very important signs and symptoms of anticholinergic activity. Anticholinergic, for example, atropine-like activity. That means you should know among the given plant, which plant having anticholinergic activity. The answer is Datura. Datura having anticholinergic property. Because anticholinergic, they cause some problem like people become dilated and there is a dryness of all secretion, like sweating will decrease, the saliva get decreased and there are also going to be constipation and retention of urine. All these symptoms are very important signs and symptoms of atropine. So Datura having anticholinergic activity, answer is atropine or Datura. Okay, next is a farmer is presented to the emergency department with garlic odor breathing, pinpoint people and excessive salivary secretion. Which of the following is the drug of choice for treating this condition? Options are flumazenil, pralidoxine, atropine, N-acetylcysteine. Very easy question. Look here. They are given a farmer. Okay, it's a very important clue. A farmer admitted or presented to emergency department with a garlic odor breathing, pinpoint people, excessive salivary secretion. Okay, So first you should know what is the diagnosis. Look here, whenever there is a history of farmer in the agriculture area using some insecticide, he may using some insecticide like organophosphorous compound. Organophosphorous compounds are irreversible cholinesterase enzyme inhibitor. That means organophosphorus compounds are going to accumulate acetylcholine. Okay, they accumulate acetylcholine. When there is an accumulation of acetylcholine will cause pinpoint pupil. Acetylcholine will cause excess salivation, and acetylcholine may cause altered water breathing. So it's a case of organophosphorus poisoning. Now you should know, for this poisoning, what is the treatment of choice? The first line drug of choice for treating OPC poisoning, atropine. Okay. Now go for discussion. Flumazenil is one of the important drugs. Actually, it is an antidote for benzodiazepines. Then pralidoxime. This is very important. Oxime. Oximes are cholinesterase reactivator. They are also useful for treatment of organophosphorus compound poisoning. But the treatment of choice, the first line drug of choice for treating OPC poisoning means go for atropine. Why? I will discuss later on. Wait for 1 minute. Look at the last option, N-acetylcysteine. Very straight question. N-acetylcysteine actually antidote for paracetamol poisoning. It's antidote for paracetamol poisoning. Okay. Now, flumazenil ruled out, N-acetylcysteine ruled out. This is a case of organophosphorus poisoning. What is this poisoning? What are the points you should recollect? Look here. Organophosphorus poison mean there are something called insecticides like parathion, malathion, diazinon. So in agriculture area, using some insecticide like parathion, malathion, diazinons. All these are called organophosphorus compound. What are they? They are cholinesterase inhibitor. That means they are going to inhibit cholinesterase activity. Now just I will explain simply. Look here. Imagine it's a cholinesterase enzyme. And imagine it's acetylcholine. You know physiology. Acetylcholine normally undergo metabolism by, that is inactivated by cholinesterase enzyme. Okay. Now, physiology says cholinesterase enzyme having two sites. One is called anionic sites. One more thing, estetic sites. I am going in depth. It's very important. Now, what happened in case of organophosphorus poisoning? For example, if a farmer, imagine if a farmer taken organophosphorus compound like parathion or malathion, what they will do? They will bind with the estetic sites and causes inhibition of this enzyme. So, organophosphorus compound inhibiting cholinesterase enzyme. So, the cholinesterase enzyme inhibitor. When this enzyme is inhibited, this compound going to cause accumulation of acetylcholine. Look here. When acetylcholine get accumulated, usually acetylcholine will act on muscarinic and nicotinic receptor. Now, by acting on muscarinic receptor, they are going to cause some symptom like gastric ulceration, bradycardia, bronchospasm, diarrhea, urination, meiosis, pinpoint people, increasing secretion like salivation, sweating, all these things. By acting on nicotinic, they cause muscle contraction, muscle twitching. Okay. Now look here. In OPC poisoning, look at the symptom. Majority of symptoms are due to muscarinic receptor activation. So, the first line drug of choice for treating OPC poisoning is anti-muscarinic agent, because most of symptoms due to muscarinic. So, give anti-muscarinic, for example, atropine. So, atropine is the first line drug of choice for treatment of OPC poisoning. Okay, but atropine will control only the muscarinic symptom, only muscarinic. It will not take care nicotine symptom. So, for complete recovery, for complete therapy, we have to reactivate this enzyme. When you reactivate this enzyme, this acetylcholine may undergo inactivation, so all the symptoms can be subsided. So, for complete treatment, I want to reactivate this enzyme. For that, I have one group of drug called AIIMS. They call choline esterase reactivator. Look here. When they say AIIMS, what they will do? The AIIMS, when I give, they going to bind on anionic sites. By acting on anionic site, they will cause reactivation of choline esterase. So remember, AIIMS are called as choline esterase reactivator. What are the examples for the AIIMS? The examples are we having pralidoxime, obidoxime and diacetylmonoxime. So they are second line choice. So remember, for treating OPC poisoning, first line choice will be atropine. Very important, very important. And then other choice will be we go for oxime like P2AM. That is pralidoxime or obidoxime or diacetylmonoxime. Oxime is also useful. Okay, right. Next question. Among the oxime, obidoxime more potent, and among the three oxime, diacetylmonoxime highly lipid soluble, easily able to cross the blood-brain barrier, having more CNS activity. That's all extra points. Okay. Now, simple state question. An elderly male patient developed dementia and was diagnosed as Alzheimer's disease. Which neurotransmitter level is reduced in this patient? Very straight question, man. They are telling the patient was diagnosed as Alzheimer's disease. And you know, in Alzheimer's there is a dementia, memory loss. They are asking what is the neurotransmitter pathology in Alzheimer's disease. Remember, in Alzheimer's disease, the main problem is deficiency of acetylcholine. Remember, deficiency of acetylcholine is the main problem. Okay. So, answer for this question is acetylcholine. Right. Now look here. Usually, Alzheimer's patient may have memory loss problem. They have problem in memory. And the fundamental pathology, there is a deficiency of acetylcholine in their brain. Okay. So, when you want to give treatment for Alzheimer's, you should increase the acetylcholine level. That means you need cholinergic enhancers. So, for treating Alzheimer's, we need cholinergic enhancers like rivastigmine, donepezil, galantamine, taquine. All these drugs are going to increase acetylcholine level in the brain, thereby useful for treatment of Alzheimer's. In this, rivastigmine, donepezil, galantamine are commonly used. Whereas taquine is not in use because this drug causing side effect of severe side effect of hepatotoxicity. So this drug is not used nowadays. Okay. Remaining three drugs are useful. In this case, one more interesting MCQ question you have to know, that's called for treating Alzheimer's, we have another group of drug called NMDA blocker. N-methyl D-aspartate, NMDA blocker called memantine. Memantine is an NMDA blocker approved for treatment of moderate to severe Alzheimer's. For treating moderate to severe Alzheimer's disease, we are using memantine. Okay, that is about treatment for Alzheimer's. Anyway, your question is, what is the problem in Alzheimer's? The problem is due to deficiency of acetylcholine neurotransmitter. Okay. So, these are the recalled question from your pharmacology paper, FMGE paper from AIIMS part. Now we go for CNS. What are all the questions asked in FMGE in CNS? Okay. An elderly patient presented with a tremor, muscle rigidity and bradykinesia, and was diagnosed as a Parkinson disease. Which neurotransmitter level is reduced in this patient? Straight question, man. I think this is again very simple straight question. Okay. Look here. Elderly patient present with the tremor, muscle rigidity and bradykinesia. That's called hypokinesia. By using the symptom itself, we can say that Parkinsonism, and they also given the clue. The patient was diagnosed as a Parkinson disease. Which neurotransmitter level is reduced in this patient? Options are acetylcholine, dopamine, noradrenaline and serotonin. Straight question. The answer is deficiency of dopamine. Look here. Very simple question. Look. What is the fundamental pathology in Parkinson disease? Look at this point. Actually, look at the black color fiber. It is called nigrostriatal neuron. Nigrostriatal neuron extending from substantia nigra is called substantia nigra. From here, it goes to corpus striatum. Corpus striatum. That's why it's called nigrostriatal neuron. Actually, for you and for me, what is the function of this neuron? The actual physiology will be this neuron causing synthesis, storage and release of dopamine as a transmitter in the corpus striatum. And the dopamine in the striatum responsible for initiation of movements. If I want to walk, if I want to go for this, the movement, initiation movement is done by dopamine in the corpus striatum. But in the corpus striatum, we not only having dopamine, we also having some more transmitter like acetylcholine. Acetylcholine. Now look at the point. Normally, you as well as me, all the normal people in our corpus striatum having balanced amount of, that is equal amount of acetylcholine and dopamine. You know from physiology, acetylcholine in the muscle causing muscle contraction. Okay. And today you know dopamine causing initiation of movements. Now, in the basal ganglia, in the corpus striatum, we having balanced amount of acetylcholine and dopamine. Now, as age advances, as we grow old, in old age, this neuron, that is nigrostriatal neuron, this neuron undergo degeneration. Now listen, when the neuron undergo degeneration, it is not able to synthesize, store and release dopamine. It is not able to cause adequate release of dopamine. Come on. When dopamine is not released adequately, this balance getting altered. Thereby, there is a deficiency of dopamine with a relative overaction of acetylcholine going to occur. Relatively overaction ACH. So, when there is a deficiency of dopamine, the movement initiation become poor. It's called bradykinesia. When there is an increased ACH, that causes too much a contraction, muscle rigidity, sometimes tremor. So look here, a patient having bradykinesia, muscle tremor and rigidity, diagnosis Parkinsonism. So the fundamental neurotransmitter pathology causing Parkinson, think of deficiency of dopamine and relatively overaction of ACH. The main problem, deficiency of dopamine, that causing bradykinesia. That's why for treating Parkinsonism, we give dopaminergic drug like levodopa or bromocriptine like that. Okay, that's a problem. Next question. A pregnant lady with a history of previous child with Down syndrome, currently on lithium therapy, presented for antenatal checkup. Which of the following condition is the fetus at the greatest risk of? Very simple question, but they ask in complicated way. That's all. Question very simple. Look here. Pregnant lady having the history of previous child with Down syndrome. Now she is on lithium therapy for her psychiatric problem. She presented for antenatal checkup here. If a pregnant lady on lithium therapy, the child is having greatest risk of developing what problem? What teratogenicity? Look at lithium is the teratogen going to cause fetal abnormality. So the question is, what is the fetal adverse effect of lithium? That's all. So the answer for the question, come on, options are Down syndrome, tetracephalate, Epstein anomaly, needle to defect. What answer? The answer is Epstein anomaly. Epstein anomaly. So lithium, a drug useful for treatment of bipolar disorder, and it's a teratogen. It causes Epstein anomaly, where the patient, the baby born with tricuspid atresia, cardiac problem like that. Okay. Now, for this question, you should know some more point actually. I told lithium, a drug useful for treatment of bipolar disorder. Okay. This drug having narrow therapeutic index. Therapeutic index is a marker of safety. When I say narrow therapeutic index is unsafe. It causes so many problems. Look at the problem. For the problem, you just go through drug name, lithium. Adverse effect, lithium. LA mean you can think leukocyte counts are increases, called leukocytosis. T, it may cause tremor, fine tremor. H mean hypothyroidism. Lithium may cause hypothyroidism because lithium inhibiting release of T3, T4 from thyroid follicle. IU mnemonic increase urination. That means polyuria. Lithium can cause polyuria. It is called lithium induced diabetes insipidus. And for treating this condition, we use one drug called amiloride. This point is important. Please note the point. One of the side effects lithium is diabetes insipidus. For treating lithium induced diabetes insipidus, we give amiloride. What is amiloride? Amiloride is a potassium sparing diuretic, comes under ENaC, epithelial sodium blocker. ENaC blocker, ENaC, mean epithelial sodium channel blocker. And M in mother, that is pregnant. In pregnant lady, for treating bipolar disorder, if we give lithium, it causes teratogenicity, that's called Epstein anomaly. So this is your FMG question. What is the fetal adverse effect of lithium? Lithium causing teratogenicity in the form of Epstein anomaly, where the baby having tricuspid valve atresia. And also they have flabby infant syndrome, muscle become flabby, and there's a fetal hypothyroidism. Apart from this adverse effect, you should also know lithium may cause other problem, T wave changes in the ECG, and may also cause exacerbation of skin problem in psoriasis patient. Okay, but again very important point you should know, since it's a teratogen, remember, lithium absolutely contraindicated for treating bipolar disorder in pregnant lady and in lactating mother. So in pregnancy and lactating mother, lithium absolutely contraindicated. Okay. One more contraindication, lithium unsafe in a patient with a sick sinus syndrome. In this area, one more extra point you should know. I told lithium is unsafe for treating bipolar disorder in pregnancy. So, for treating bipolar disorder in pregnancy, what is the best option? The best option, we can go for atypical antipsychotic. So, remember, for treating bipolar disorder in pregnancy, we can use atypical antipsychotic agents. But lithium contraindicated. Okay. Next. Which one of the following antidepressant acting by inhibiting reuptake of both serotonin and norepinephrine? This question is about antidepressant. Actually, they are asking only classification based question. They are not gone in depth. Only superficially asking classification. Which one of the following antidepressant acting by inhibiting reuptake of both serotonin and norepinephrine. Options are fluoxetine, phenelzine, venlafaxine, amitriptyline. Look here. Here, fluoxetine is very simple question. It's a SSRI, selective serotonin reuptake inhibitor. Okay. Then, phenelzine is a MO, monoamino oxidase inhibitor. So, these two things ruled out. Now, the options are C and D, venlafaxine, amitriptyline. This is a confusion. Look here. Venlafaxine actually is a SNRI. SNRI. What is SNRI? Serotonin norepinephrine reuptake inhibitor. So for this question, you can choose the answer venlafaxine. No doubt at all. But the doubt is regarding amitriptyline. Look here. Amitriptyline actually a tricyclic antidepressant. This drug also acting by inhibiting. This also inhibiting reuptake of both serotonin and norepinephrine. Okay. So TCA, tricyclic antidepressant, also having same action. But why this is called SNRI? Why this is called TCA? These drugs in their chemical structure, they have 3 cyclic ring. In the chemical structure, they have 3 cyclic ring. That's why called tricyclic antidepressant. But mechanism action wise, both the group having almost same function, inhibiting reuptake of both serotonin and norepinephrine. So it's an ambiguous question. You can vote for C as well as D, but both the right answer in my point of view, because both the drug having action of inhibiting reuptake of serotonin and norepinephrine. Okay. Next. A patient was given halothane for general anesthesia. He developed muscle rigidity, hyperthermia. Which one of the following ion responsible for this symptom? Very straight question. The patient was given halothane for general anesthesia. Following halothane therapy, the patient developed muscle rigidity and hyperthermia. Look here. Whenever a general anesthetic agent causing muscle rigidity and hyperthermia, mean it may be a case of malignant hyperthermia. In case of malignant hyperthermia. Now question starts. Here, the most important ion responsible for this problem is calcium. The calcium is the one causing muscle contraction and more release of energy, heat, causing hyperthermia. Okay. Now, in this junction, 2 important points you should recollect. For example, look here. In our skeletal muscle, we have one thing called sarcoplasm. The sarcoplasm is the storehouse of calcium. And on the sarcoplasm, we have ryanodine receptor. Normally, from the sarcoplasm, via ryanodine, calcium may get released. This calcium causing muscle contraction. It's normal. But there are some drugs like halothane or sometimes succinylcholine, a muscle relaxant. These drugs which are used in anesthesia, these drugs, especially in a patient who having abnormality in ryanodine receptor, those who having abnormality in ryanodine receptor, in that patient, when you give halothane or succinylcholine, there's a more and more release of calcium, causing too much of muscle contraction, causing muscle rigidity and hyperthermia. It's called malignant hyperthermia. So, here the problem is due to calcium. That is the FMGE question. Okay. So, halothane, a anesthetic agent, succinylcholine, a skeletal muscle relaxant, may cause malignant hyperthermia. Here the problem is due to release of calcium via ryanodine. So, in this extra point, suppose asking what is the treatment for malignant hyperthermia, mean you should block the release of calcium from sarcoplasm. That is done by one drug called dandrolene. Dantrolene going to block ryanodine, thereby blocking the release of calcium. What is dantrolene? Is the directly acting skeletal muscle relaxant. It's a very good drug for treatment of malignant hyperthermia. Okay. So for FMGE level, remember the hyperthermia rigidity following halothymine is due to overaction of calcium ion. That's an important point. Next, a drug addict patient was presented with agitation and ulceration in the skin. This patient had severe itching and scratch marks on the body. On examination, he had tachycardia, hypertension and mydriasis. Which are the following substance responsible for this symptom? Very stage question, man. So patient is a drug addict having agitation, ulceration in the skin and having itching over the body and having tachycardia. Come on, heart rate is fast, tachycardia, and having high BP, BP is very high, and having mydriasis, look here, heart rate is high and BP high and having mydriasis, mydriasis means dilatation of people. If these are the symptoms, these signs and symptoms are telling about overaction of adrenaline. So there is a substance going to increase acetylcholine level. Adrenaline. The substance going to increases adrenaline level, thereby increase heart rate, increase in BP and causing mydriasis. Who is that drug? That drug is cocaine. Look here. Cocaine is a psychiatric drug and also having local anesthetic activity. Look here. The cocaine has one important action, that is cocaine may cause, inhibition of reuptake of norepinephrine. Okay, cocaine inhibits reuptake of norepinephrine. That means cocaine increases the catecholamine activity. By increasing catecholamine activity, it causes agitation. It causes increase in heart rate, increase in BP, and also causing mydriasis. So, a substance that going to cause, that the addictive substance going to cause elevation of catecholamine activity means think of cocaine. Cocaine, addictive substance and also having local anesthetic property, and one more important property, inhibiting reuptake of norepinephrine, thereby accumulates norepinephrine, increases catecholamine activity, thereby causing high blood pressure, high heart rate and also mydriasis. That's about important recall question from your CNS. Okay. So, ANS chapter question I recollected and CNS question I have recollected. Now we go for what are the important questions. We are recollected from FMGE paper from respiratory system. Look here. Which one of the following drug is useful in emergency management of asthma but does not cause bronchodilation? Look here. Very straight question, little bit tricky. Look here. Which one of the following drug useful in emergency management of asthma but the drug does not causing bronchodilation? Look here. Actually in bronchial asthma there is a bronchospasm. So in emergency we need bronchodilators. Look at the option: salbutamol, ipratropium, theophylline, hydrocartisone. Salbutamol we know is a beta-2 agonist. It's a very good bronchodilator. It's a very good choice for acute attack of asthma. Ipratropium is very simple, anticholinergic agent. It is also a bronchodilator. Theophylline, Actually, theophylline is a phosphodiesterase enzyme inhibitor as well as having adenosine receptor antagonism property. Adenosine receptor antagonism property. It is also having bronchodilatory action. So, A, B, C, these three drugs are bronchodilators, useful for asthma. Among this, the most superb choice for acute attack asthma short-acting beta-2 agonists like salbutamol. Whereas hydrocartisone is a steroid. It can be useful for treatment of acute asthma, but it is not a bronchodilator. So, answer is hydrocartisone. Hydrocartisone is the corticosteroid. It is mainly used for anti-inflammatory purpose to control airway inflammation. It's an anti-inflammatory agent useful to control airway inflammation. It can be useful for acute attack, but it is not a bronchodilator. Right. Next question. What are the questions asked in FMGE paper from CVS chapter? That is CVS blood and kidney chapter. Okay. Which one of the following is the drug of choice for digoxin-induced ventricular tachycardia? Look here. Digoxin, an important drug useful for treatment of congestive cardiac failure as well as useful for treatment of atrial fibrillation and for atrial flutter. Atrial flutter. This is a very good drug. But this drug causing so many problems. It may cause cardiac problem, non-cardiac problem. The question is about which one of the following is the drug of choice for digoxin-induced VT. See, digoxin is a pro-arrhythmogenic. When you talk about adverse effect of digoxin, digoxin is a pro-arrhythmogenic agent. Pro-arrhythmogenic. That means this drug itself causing arrhythmia. It may cause atrial tachycardia. It may cause ventricular tachycardia, it may cause AV block, any type of problem can occur. But the question, which is the drug of choice for treating digoxin-induced ventricular tachycardia? The options are atropine, amiodarone, lidocaine, procainamide. The right answer is option C, lidocaine. Lidocaine is also called lignocaine. It is also called lignocaine. Okay. It is actually a class 1B anti-arrhythmic agent. It's very useful for treatment of digoxin-induced ventricular tachycardia. Now, I will just give one simple thing. How to treat a digoxin toxicity? So, put the title, Treatment for Digoxin Toxicity. Whenever you suspect digoxin toxicity, first thing you should do is check for serum, potassium, calcium and magnesium. Whenever you suspect digoxin toxicity, first thing check for serum calcium, potassium and magnesium because in case of hypokalemia or in case of hypercalcemia or in case of hypomagnesemia, these are the electrolyte imbalance going to aggravate digoxin toxicity. So first thing is, whenever there is a digoxin toxicity, check for electrolyte imbalance. If there is imbalance, correct the problem. So first thing, correction of hypokalemia, hypomagnesemia and hypercalcemia. That's the first thing. And then going for specific therapy. For example, a digoxin may cause atrial tachycardia. For treating digoxin-induced atrial tachycardia, we can use propranolol, a beta blocker. Then, digoxin may cause AV block, atrioventricular conduction block. For treating this block, we can use a drug called atropine, anticholinergic agent. And for your FMG, the question was, digoxin may cause VT. For treating digoxin-induced VT, what is treatment? Here the best is lignocaine, or we can use phenytoin sodium. Look here, phenytoin actually anti-epileptic agent. It's also having anti-arrhythmic activity useful for treatment of digoxin-induced VT. But among the two, the best drug of choice for treating digoxin-induced vitamin, think of lignocaine. And then one more point, we have one specific antidote for digoxin toxicity. This is again very important question. The antidote for digoxin toxicity is digibind. And finally, one more point you should know, in case of digoxin poisoning, there is no role for dialysis. Remember, there is no role for hemodialysis in the treatment of digoxin toxicity because digoxin having large volume of distribution. Any drug having large volume of distribution cannot be benefited by using dialysis. So, there is no role for dialysis in the treatment of digoxin toxicity. So, anyway, for your level, for digoxin-induced VT, this is the question, choice is lignocaine. Again, one more question you should know, the antidote for digoxin toxicity is digibind. Next question. A female patient was taking warfarin for prosthetic heart valve. She became pregnant. What advice will you give for this patient regarding use of this drug in early pregnancy? Very simple but clinical question. Look here. A female patient was taking warfarin. Warfarin, you know, orally given anticoagulant. It's an anticoagulant for prosthetic heart valve. Because prosthetic valve, when you implant prosthetic valve, it may cause thrombus and embolism. To prevent thromboembolism, lifelong we have to put them on anticoagulant like warfarin. Now, after marriage, she became pregnant. While on pregnant, what advice will you give for this patient regarding use of this drug in early pregnancy? Options are continue warfarin without any concern, continue warfarin but add vitamin K, change warfarin to heparin, or terminate the pregnancy. What answer? See, patient is on warfarin. If the patient continues warfarin during pregnancy, remember, warfarin is the teratogen. Warfarin is the teratogen. So, there is a problem. So, patient is having prosthetic valve. When they have prosthetic valve, definitely they must be an anticoagulant for lifelong. So, what I should do? Here, the best part is stop warfarin, use heparin in early pregnancy. That's the first trimester. Okay, look here. Why? Why is this answer? I will tell. Actually, warfarin is unsafe in pregnancy because warfarin is a teratogen. It may cause fetal chondrodysplasia punctata. It is also called Conradi syndrome. So, in early pregnancy, if the lady continues warfarin, there is a risk of teratogenicity. That is called fetal warfarin syndrome, also called Conradi syndrome, also called fetal chondrodysplasia punctata. So, warfarin should be stopped in the first trimester. Here, the safest drug will be go for either heparin or go for low molecular weight heparin like enoxaparin, nadraparin, like that. Okay. So, the safer anticoagulants are injectable anticoagulant like heparin or LMWH. LMWH means low molecular weight heparin, whereas warfarin unsafe in pregnancy. Okay. Next question. A patient present to hospital with road traffic accident. This patient has raised intracranial pressure without intracranial hematoma. Which of the following drug is preferred for management of this patient? Okay. A patient presented to hospital with road traffic accident, following which there is raised intracranial pressure, but there is no hematoma, there is no hemorrhage. Which of the following drugs preferred for managing this patient? Actually, this patient having increasing intracranial tension following road traffic accident. So, for treating the increased intracranial tension, the best choice will be go for mannitol. Mannitol is an osmotic diuretic. It's a very good choice for treatment of cerebral edema. Cerebral edema. See, whenever there is a what called transient ischemic attack or cerebrovascular accident, in this case will be there's a risk of cerebral edema. So to treat the edema, we can use mannitol. But once again, mannitol is not safe in hemorrhagic cases. So this patient having no hemorrhage. That's why I preferred mannitol. Remember, mannitol is a very good choice for non-hemorrhagic ischemic stroke. So for treating ICT without intracranial hemotomy, I go for mannitol. It's a very good choice. It's osmotic diuretic. That finishes some recalled question from CVS chapter. So ANS chapter, CNS chapter and CVS chapter and RS chapter recalled question over. Next we move on to endo recalled questions. Look, which one of the following radioactive iodine useful in the treatment of thyroid cancer? Look here. Options are iodine 123, iodine 125, 127, iodine 131. Very simple, very simple. For treating a thyroid cancer, we can use radioactive iodine, but the best choice iodine 131. Okay. Here 3 to 4 points you should recollect. What are the points? Point 1. There is a role for radioactive iodine therapy in the treatment of thyroid cancer. The radioactive iodine is 131. Iodine 131. It has half-life of 8 days. This is also MCQ. The half-life of iodine 131 is 8 days. Here, first point, the iodine 131 emitting two rays. One is gamma ray, one is beta ray. So radioactive iodine emitting two rays. One is called gamma ray, one more thing beta ray. And the penetration power, penetration power of this radiation is 0.5 to 2 millimeter. Okay, here one more point. The gamma ray useful for diagnostic purpose. Gamma ray useful for diagnostic. Beta ray useful for therapeutic purpose. Okay, now I want to know what are all the therapeutic uses of radioactive iodine 131. Come on. It is useful for treatment of hyperthyroidism, especially in older patients and heart dissipation, and also for thyroid cancer. This is what your FMGE question. Which is the radioactive iodine useful for treating thyroid cancer? Answer is radioactive iodine 131. Okay, and it is also useful for thyroid scanning because the gamma ray useful for diagnosis purpose. But one very interesting point you should know: radioactive iodine is contraindicated in case of pregnancy, young children, and in ophthalmopathy patients. Graves ophthalmopathy, because iodine 113 going to cause aggravation of eye disease, unsafe in pregnancy, unsafe in young age patient, and in ophthalmopathy. Okay, next. Which one of the following anti-diabetic drug does not require dose reduction in kidney failure? Question is, which one of the following anti-diabetic drug does not requiring dose reduction in kidney failure? Options are linagliptin, vildagliptin, saxagliptin, sitagliptin. The right answer is option number A, linagliptin. Why? Actually, look at this. All the drug ending with the name gliptin. So, gliptins are a group of drug called DPP4 inhibitor. DPP means dipeptidyl peptidase 4 enzyme. So we have one group of drug called DPP4 inhibitors. dipeptidyl peptidase 4 inhibitor. They are given orally. Example, sitagliptin, saxagliptin, linagliptin, vildagliptin, allogliptin. So all the drug name are ending with a suffix called gliptins. Gliptin. So gliptins are orally given anti-diabetic drug. They call DPP4 blocker. Here, your question is, look here. All the gliptin, look at the excretion, all the gliptin undergo renal route of excretion. That means all the gliptins are unsafe in kidney failure. Your FMGE question, which is the one safe in renal failure? Look here, we have one drug called linagliptin. That drug undergo excretion via bile, that is through liver. Since they undergo excretion via bile, it is safe in kidney failure. So, which is the DPP4 blocker safe in kidney failure? Mean, think of linagliptin. That's the question. Next, hormone and the endogenous substance that are involved in the regulation of calcium balance in the body are. Very simple question. Hormone and the endogenous substance that are involved in regulation of calcium balance in the body are vitamin D, parathermone, calcitonin, or option B, vitamin D, parathermone, TSH, thyroid stimulating hormone. Option C, vitamin D, parathermone, insulin. Option D, vitamin D, calcitonin, TSH. What answer? Straight answer, man. It is vitamin D, parathermone, calcitonin. These are the calcitonin, parathermone or hormone, vitamin D, endogenous substance. They are the one going to regulate calcium balance. Here, one extra point you should know: the calcium responsible for bone health, and the bone health is depends upon the two important bone cells called osteoblast, osteoclast. Osteoblast, blast mean bone forming agent. They call bone forming agent. Osteoclast mean they cause resorption. They causing bone resorption. So, to maintain the bone health, there is equal activity of osteoblast, osteoclast. So, whenever there is a osteoporosis, look here. Whenever there is a osteoporosis, that is bone weakness, mean for treating osteoporosis, either we have to use osteoblastic drug or we have to inhibit osteoclastic cells. That's the concept. Now, the hormones and the endogenous substance that are maintaining calcium balance, thereby maintaining bone health, are parathermone, vitamin D, and calcitonin. This is the question. FMGE question. Just go one step forward. The parathermone, vitamin D, they have anabolic action. That means bone forming activity, osteoblastic activity. Whereas calcitonin inhibit osteoclastic activity. So all these drugs can be useful for treatment of osteoporosis also. So remember, parathermone like teriparatide, abelaparatide, parathermone analogs, vitamin D, and then calcitonin, all are having role in the treatment of osteoporosis because they are maintaining bone balance, calcium balance. Okay. Next question. Which one of the following is the longest acting phosphodiesterase enzyme inhibitor? Question is longest acting phosphodiesterase blocker. Option given are sildenafil, tadalafil, verdenafil, avenafil. Look at all these options given are PDE, phosphodiesterase 5 enzyme inhibitor, all are PDE5 blocker. All these drugs are useful for treatment of erectile dysfunction. Now for FMG, the question was, which one of the following is the longest acting phosphodiesterase enzyme inhibitor? The right answer for the question is tadalafil, longest acting. Tadalafil. Now coming to a point. Actually, For treating erectile dysfunction, we use a group of drug called PDE5 inhibitors. Example, sildenafil, vardenafil, tadalafil, avenafil. Your question is, which is the longest acting? LA means longest acting. Answer, tadalafil. Actually, what they does, when I talk about mechanism action, these drugs are, by inhibiting PD5 enzyme, they cause accumulation of cyclic GMP. By accumulating cyclic GMP, they cause vasodilatation. By causing vasodilatation, they cause erection. So, they are useful for treatment of erectile dysfunction. But here one very important point you should know. We have one group of drug called nitrates. Nitrates are group of drug useful for treatment of angina, chest pain due to coronary artery disease. Okay, the nitrates acting by accumulating cyclic GMP. So nitrates also causing vasodilatation. Now what I want to tell is, whenever a patient is taking sildenafil, sildenafil plus nitrates or any one of the PD5 blocker with the nitrate, what happened? The problem is, look here, when they given combination of sildenafil nitrate, both are acting by accumulating cyclic GMP, and both when they given combination, they cause severe vasodilatation, thereby sudden hypotensive shock can occur. So remember, doctor, sildenafil should not given along with the nitrate. So nitrate and sildenafil should not use concurrently. That point. And finally, for treating erectile dysfunction, we have some injectable drug. What are the injectable therapy available for treatment of erectile dysfunction? There are some drug can be injected into penis. They call alprostadil, a prostaglandin E1 analog. Phentolamine, a non-selective alpha blocker. Papaverine, it's also non-selective phosphodiesterase enzyme inhibitor. They can be used injectably for treatment of erectile dysfunction. Okay, that's about some important recalled question from endocrinology. Next, autocoids. There are two questions they ask in FMGE from autocoid chapter. One question is, look here. Which one of the following drug is useful for medical closure of patent ductus arteriosus? Look here. Medical closure of patent ductus arteriosus. Options are indomethacin, alprostadil, mefenamic acid, paracetamol. State question, the drug of choice, indomethacin. Indomethacin, a non-steroidal anti-inflammatory drug, going to inhibit prostaglandin synthesis, thereby causing vasoconstriction. So, useful for closure of ductus arteriosus, think of indomethacin. Whereas alprostadil is a PGE1 analog. It's a vasodilator. It is useful for maintaining the patency of ductus arteriosus. Whereas mefenamic acid is also NSAID, that is mainly used as an analgesic, especially useful for treatment of menstrual pain. Paracetamol is an analgesic agent plus antipyretic agent with a poor anti-inflammatory activity. So answer is indomethacin. Next, a female patient was prescribed with presented with pain and redness in her great toe. Pain and redness in great toe. Okay. Serum uric acid level was 9.7. Okay, so much more than the normal. It's this high level. Apart from prescribing analgesic to relieve pain, the physician prescribes a drug that can decrease the formation of uric acid. Which of the following enzyme is likely to be inhibited by this drug? Okay, options are thymidylate synthetase enzyme, dihydrofolactase enzyme, xanthine oxidase enzyme, phosphoribosal transferase enzyme. It's a very funny, simple question. See, the patient having pain and also redness in her grade 2, that main clinically diagnosis of gout. And this confirmed by uric acid level. That's a high amount of uric acid, definitely gouty arthritis. So for treating the pain, they given painkiller analgesic. Here, to treat the gout, I have to suppress uric acid formation. Uric acid synthesis can be blocked by some drug like febuxostat and allopurinol. These drugs are acting by inhibiting xanthine oxidase enzyme. The xanthine oxidase enzyme is the one responsible for uric acid formation. So, for treating gouty arthritis, we have one group of drug called xanthine oxidase enzyme inhibitors. Xanthine oxidase are enzyme involved in production of uric acid, so that can be blocked by using febuxostat and allopurinol. Remember, febuxostat and allopurinol both are xanthine oxidase enzyme inhibitor useful for gouty arthritis. Next, there are two questions from antimicrobial. 1. Which one of the following antimicrobial is contraindicated in a patient with a seizure disorder? Options are ampicillin, cefixime, ofloxacin, erythromycin. State question, man. Usually, quinolones are causing side effect of seizures. So, quinolone unsafe in seizure patient. Whereas, ampicillin, cefixime are beta-lactam antibiotic. They don't cause seizure. Erythromycin, a macrolide group of drug that mainly causing diarrhea problem and also reversible deafness problem, rarely cholestatic jaundice, but they don't cause seizure problem. Okay. Next, a patient traveled to Assam. After coming back, he developed a fever, chills, rigor, and altered sensorium. Peripheral image shows presence of falciparum. What is the treatment choice for this patient? Look here. Patient having symptoms of fever, chills, rigor with altered sensorium, and the blood test peripheral image shows falciparum. So it's malaria. But it's not only fever, altered sensorium. That means there is a problem in the brain. Maybe cerebral malaria, one of the complicated version of malaria. Remember, for complicated malaria and for treatment of multi-drug resistant malaria, today the drug of choice will be artemisinin. Artemisinin group of drugs are drug of choice for treatment of cerebral malaria and also for multi-drug resistant malaria. So, answer for the question is artemisinin. But usually artemisins are combined with other anti-malarial. That is called ACT. That means artemisinin combination therapy. Because artemisins are fastest acting. They immediately control symptoms of malaria. But they are short acting, so more chances of recurrence. So to avoid the recurrence, we give along with the other anti-malarial drug. They are called ACT, artemisinin combination therapy. For this question, straight answer artemisinin. Next, recall the question from general pharmacology. Which one of the following vitamin will increases absorption of iron from stomach? Look here. Actually, iron, you call iron, this is used for anemia. this drug will be more absorbed in acidic medium, that means better give along with the ascorbic acid. Vitamin C is also called ascorbic acid. So that will facilitate the absorption ion. Okay. Next question. From the given image, find out the true statement. They given something called log dose response curve. It's called DRC, dose response curve. Based on the dose response curve, they are asking which is more potent, which is less potent, which are having more efficacy, which have equal efficacy, like that. This is a very simple question. First, note down the answer. I will explain. The answer for the question is option D. Why D? I will explain. Listen carefully. Look here. There is one thing called log dose response curve. Remember, it's very important, very important. Look, I put x-axis and y-axis. Imagine the x-axis, imagine the y-axis. In the x-axis, I put dose value, log dose value. In the y-axis, I put response value. For example, look here. I want to test the actions of acetylcholine in skeletal muscle. Okay. So, imagine I am dissecting a frog rectus muscle. In the frog rectus muscle, I am injecting acetylcholine. I am seeing the muscle contraction. I am measuring the contraction also. So now what I am doing? I am going to inject acetylcholine. When I start injection, I will give low dose. For this dose, how much amount of contraction occur? That is called response. The response I am measuring and putting in the y-axis. So dose value in the x-axis, response value in the y-axis, and gradually I am increasing the dose. When I increase the dose, I am getting increased amount of muscle contraction, increased response, and then increase in dose, increase response, increase in dose, increase response, increase in dose, increase response. Now I am just connecting all my response. If I connect, I get one curve. So it's called log dose response is a curve, log dose response curve. Okay. In this first point, look at the first point. In this first point, what is the shape of the curve? The shape of the curve is sigmoid, sigmoid in shape, or simply S shape. Okay. Here, look at the height of the height. Look at the height of the curve. The height of the curve indicate efficacy. Efficacy. This is called efficacy. And from here, just draw one small line. This dose. This dose. This is the dose at which I am getting highest response. MR means maximum response. Maximum response. The maximum response is called as efficacy. The dose at which I am getting a max response, that's called maximum dose. Just one point. The maximum response of the drug is called efficacy. The next point, look here. The dose at which, look at this, the dose at which I am able to get half of the, that is 50% of the maximum response. Maximum response means 100%. Okay. The dose at which I am getting 50% of max response, that dose is called ED50. What is ED50? ED means effective dose. Effective dose 50. That is the dose at which I am getting 50% of maximum response. That is called ED50. This is called potency of the drug. So ED50 indicate potency of the drug. That means even with the less dose, if I are getting a very good response, that is more potent. That is more potent. Whereas to get the response, if I need more dose, means that is less potent. So the ED50 indicate potency, whereas max response indicate efficacy. With this knowledge, now look here. Imagine I have 3 drugs. drug A, drug B, drug C. I am plotting the dose response curve of all this A, B, C drug. Here I am putting the dose value in the x-axis, in the y-axis response value. The dose under starting here 0, 1, 2, gradually increasing dose. Now you should know, comment on drug C. Come on, comment on drug C regarding efficacy and potency on comparison with the drug A. Come on, just compare drug C with drug A. The drug C having less response, that means less efficacy. Only at the high doses it produces activity. We call less potent, less potent. So drug C is less potent, less efficacy. Whereas drug A, look here, drug A even with the low doses having very good action. So it's called most potent, most potent. And look at the heights, the drug A and drug B, they have almost the same response. So these two drugs having same amount of efficacy. So drug A and drug B in this graph having same amount of efficacy. Drug A is the most potent. Overall among the three curves, drug C is less efficacy and less potent. Like that you should comment. Now coming back to your question in FMGE, okay. They given drug A, drug B, drug C, drug D. Now look here, drug D is the most potent but less efficacy. Drug A and drug B having equal efficacy, but drug A is more potent than drug B. Overall drug C is the least potent. Like that you should not occur. So remember 2 points. What is efficacy? Efficacy means maximum response. What is potency? Potency means ED50. That's all. Okay. Next question. I think last question. Okay. A 4-year-old boy drank full bottle of iron syrup. What is the antidote for acute iron poisoning? Options are D. Penicillamine, B. AL, British anti-levisite, desferriaxamine and EDTA. Very straight question. For acute iron poisoning, the drug of choice is desferriaxamine. It's an chelator. Okay. Actually, you should know something about chelating agent. In case of heavy metal poisoning, we use some chelating agent. For example, for majority of heavy metal poisoning, a broad spectrum antidote is BAL, British anti-levisite. See, for treatment of lead poisoning, arsenic poisoning and for mercury poisoning, for these poisoning, a broad spectrum chelating agent is BAL. But one question you should know, the BAL is contraindicated for treating iron poisoning and cadmium poisoning, because when you give BAL for treating this poisoning, they are going to form toxic compound dangerous. So BAL is contraindicated for treating iron poisoning. So for FMG, they are asking what is the drug useful for treatment of iron poisoning? For treating iron poisoning, we have iron chelator like desferriaxamine, deferriprone, one more thing, desraxacin. Remember the iron chelator. What are all the iron chelator we have? 1. Desferriaxamine. Number 2. Deferriprone. Number 3. Desraxacin. So in your question, the option given is desferriaxamine. That's a drug of choice for treatment of iron poisoning. And one more thing, for copper poisoning, we can use D-penicillamine, or else we can use trientine or zinc sulfate and potassium sulfate. In olden days, for treating copper poisoning, we give D-penicillamine, but this drug causing side effect of SLE, optic-neuritis. So today the best drug of choice for treatment of copper poisoning, answer zinc. Zinc is the best drug of choice for treatment of copper poisoning. Copper poisoning, also known as Wilson disease, for treating that poisoning. Today, best drug of choice will be zinc sulfate. Okay, I think
I have collected so many MCQ from various students, and this I given as a PowerPoint presentation, video presentation. I think this is more useful for you. Please go through the video twice or thrice, get understand, and any doubts, contact our DAMS Exclusive Club. We are ready to help you at any time. The motto is you should become a very good medico, and we are all going to help you. So utilize the opportunity properly. Do well. All the very best. May God bless you. Thank you.